Hi friends, so today I am with Dr. Niha and today we'll be discussing a very interesting topic, ophthalmological tumors. Now we have seen that in the Central Institute exam, specifically when you took at the AIMS exam, now they ask a lot of questions in which they give you a history of a child who is presented with proptosis or an adult who is presented with the proptosis, and then the history is taking you towards a diagnosis of an ophthalmic tumor, be it an ocular tumor or an intraorbital tumor. And now what we have realized is that if you're gonna just pay attention to some very specific points about that MCQ, that you will be easily able to score or to take an edge over others. So now let us discuss this topic in brief from the ophthalmological perspective and as well as the radiological approach to that particular tumor. Okay, so Dr. Niha, can we start?
Yes. So, yes, as Dr. Rajat rightly pointed, more often than not, we are getting some question on the proptosis. Take this year only, NEET 2020 had given 2 questions and they were very similar, but the answer was different. So, actually they start playing with the words. So, we want you to be very specific and every word counts there. So, how you have to actually manipulate the thing so that you don't end up giving the wrong answer there. So I have tried to prepare a flow chart that I always tell you in the classes also, that how to actually approach such kind of questions. So to begin with, you have got 2 kind of tumors, like primary and secondary tumors, and it is the metastatic tumors which are actually most common in eye. So the first very important MCQ, the most common tumor of the eye will be your metastatic tumor, secondary tumor, and not the primary tumor. Now if they are asking you specifically about the primary tumors, then you have to go 2 ways. As I always say, our eye has 2 things, a hardware and a software. So hardware is the orbit and the software is the eyeball. So you have to see whether the tumor is lying inside the eyeball or inside the orbital cavity. And as Dr. Rajat told me a very interesting thing, it is just like a real estate. So you have to see the place also and you have to see the age also. So it's very interesting here. So you have to see the age also. Otherwise you will end up giving the wrong answer. So if it is intraocular adults, go with malignant melanoma. Intraocular children, retinoblastoma. Similarly, intraorbital adults, cavernous hemangioma. Intraorbital children, rhabdomyo. Now, sometimes they will confuse you with the benign and the malignant. So, if you see in cases of the adults, the most common is cavernous, but if you ask about the malignancy, it is a non-Hodgkin's lymphoma. Overall, cavernous hemangioma. Similarly, if you see in children, most common rhabdomyo, but if they ask you about benign, dermoid. Sometimes they say epidermoid cyst, so either of the 2, dermoid cyst or the epidermoid cyst. So, sir, I would like to ask you one thing, because we will have to take your help in this respect, that we are really confused. A child coming with the proptosis and similar kind of presentations, most of the time acute inflammatory process kind of a thing is happening, and we are worried it can be cellulitis also, like it can be a cyst also, it can be a tumor also. So how to approach such kind of patients?
So first of all, Dr. Niha, I must say that if a student knows this particular flow chart, now as far as an MCQ exam is concerned, I think more than 80% of the problem is done. So basically you do not need a radiologist after this if the things have been explained in that particular way. And I will recommend almost all the students who are watching this particular video is they try to summarize everything in this particular manner, specifically when it's an important topic. And as we were discussing about the concept of that real estate, so see, tumors is all about location. Age and location, be it a bone tumor, be it a brain tumor, be it an orbital tumor or any tumor, if you're going to look at the age and the location, your majority of the diagnosis is done. Majority of the diagnosis is done. Now, as you rightly pointed it out, now if you look at intraocular tumors, and intraocular tumors, majority of time are malignant. Okay, is malignant. In children, it is retinoblastoma. In adults, it is malignant melanoma. Whereas intraorbital tumor, if you look at that, in children, the malignant tumors are more common. Whereas in adults, it is the benign tumor which is more common, and that is why if nothing is mentioned, I'm going to go with a cavernous hemangioma in adults. Whereas in children, we're going to go to a rhabdomyosarcoma. Now, what is important here is, now if you know this, because this will be mostly a clinical question, and in a clinical question the first line starts with the age of the patient with such symptom. The symptom in majority of the cases will be a proptosis, or maybe a white eye reflex, that what we say leukocoria. Okay, so age of the patient will play a very, very important role over here, and the image will only be a supportive point over you here. So now what we're gonna do is I'm gonna just take you through a very, very basic image that I want all of you to know. Now this will help you in solving the questions of the anatomy also, ophthalmology also, and radiology also. So I have highlighted onto a transfer section of the left ocular or the left orbit. Now if you could see this particular left orbit, or we can see it from this particular case. Now what you could see is the ocular globe. If you can see over here, the ocular globe. So this structure that you could see is the ocular globe. You could see the lens over here also, and then what you could see in the center is the optic nerve. If I'm gonna see optic nerve, whereas on the either side that you could see are the muscles. On the medial side has to be the medial rectus muscle, and on the lateral side has to be the lateral rectus muscle. Now first of all you need to understand the compartments. Now as Dr. Niha rightly pointed out, if a tumor is originating within the globe, then what we're gonna simply as we have just shown it to you, then that's an intraocular tumor. Whereas if I'm gonna go that, and if I'm gonna show you, if the tumor is within the orbit but outside the globe, then that we're gonna label it as an extraocular tumor, or you can say an intraorbital tumor, because it is within the orbit. Now in the radiology, this intraorbital space is also divided into a lot of components. So now what are these components? If it is between these two muscles, now there is a superior rectus and the inferior rectus also, because they are forming a cone. If it is present within the cone, this is called as an intraconal space. Okay, intraconal space. Whereas if it is lying outside the two, then that is what is called as an extraconal space. Okay, so you need to know these are the two important spaces: an intraconal within the cone, extraconal outside the cone. Sometime it is involving the cone, and these are called as conal lesions. Okay, conal lesions. Now there are lesions which are originating from the muscle per se, and they will be called as a conal lesion. So an intraorbital will be intraconal, extraconal, and if it is involving the muscle, then that's a conal space. Okay, so this is a transfer section that I want all of you to understand. Now if I take a coronal section over here, okay, if I just draw it more perpendicular, then this is the almost image that you're gonna see, depending on at what level or at the what level that image is taken. If it is taken at the level of ocular globe, this is the image that you're gonna see. If you're gonna taking it slightly posteriorly, these are the one that you're gonna see. Now if you see these images, in the center that you could see this structure is the optic nerve. And now rest everything is so simple. The muscle that is seen at the top is superior rectus. The muscle that is seen at the bottom is inferior rectus. The muscle that is seeing on the medial side is medial rectus, and the muscle that is seeing on the lateral side is lateral rectus. Obviously the tumor that is between them is the conal, which is outside them is the extraconal. Okay, so now the point to be noted is that the structures that is there in the cone is predominantly the fat, and or the optic nerve. So the tumors are somewhere originating from that particular part. Now if we know the basic anatomy on a radiological section, now let us go to an individual tumor, that what could be there, what would be the clinical presentation of that, and then what will be the radiological impression of that, which will help us in the exam. So Dr. Niha.
Okay, thank you so much. I think this is a very, very valuable information that we have got from Dr. Rajat, because clinically we used to divide it into intraocular and intraorbital, and now you have got something more intraconal, extraconal and conal. I think this will help you in getting lot of DDs, because some of the tumors could be actually ruled out just on the basis whether it is conal, intraconal or extraconal. So okay, so let us move forward and start first with the malignant melanoma. Adults से हम लोग start कर रहे हैं. This tumor is actually more common in males. So as this, he said that age is important here, even gender is important, along with the age group of 40 to 70 years. So if a male is coming to me with an intraocular tumor along with the age group between 40 to 70 years, I would first go for the fundus examination. And on the fundus, can you see we are getting a dark colored mass, and dark colored mass always clinches you towards melanin. Yes, I think I have always told you this in the class also, that whenever you are getting a dark colored lesion, always think about the melanin. So this is actually the melanoma. Now can you see the vessels over it? So this again helping you to find out that this is actually beneath the retina in the choroid. Now, I would like you, sir, to tell us how actually it would help us in diagnosing on the B scan. I have sent the patient to you, and we have something in mind that maybe it is a case of choroidal melanoma because age is clinching me, the intraocular tumor. This patient, maybe he has come with the pain, he has come with the photopsia, and I'm able to see a blackish mass. So what kind of findings I'm going to get on this B scan?
Yeah, well, I feel that an ophthalmologist, once he sent the patient to us, then most of the time they are pretty confident that this is the melanoma because of the classical appearance that they're looking at. So now on a normal B scan, that what we're going to appreciate is we're going to see a mass that is in the posterior layer of the eye, and it is causing the retinal detachment. As you could see the layer going out of the retinal detachment. Now the point to be noted is it is very, very difficult for us on an ultrasound specifically to appreciate them that that's a real melanoma. So now if somebody asks it from the exam point of view, so I'm gonna say that this direct image that they're gonna show you will be an MR. The final diagnosis of the melanoma will be classically shown on an MR. Now we all know that when you do an MRI on a T1 weighted images, there are very, very few things which are hyper intense, and one of them is melanin pigment. Melanin pigment is hyper intense on a T1 weighted MR. Now as you could see that this is the axial T1 weighted MRI. Now as you could see the fluid is appearing so black, the gray matter is appearing gray and the white matter is appearing white. So this is a T1 weighted MR. Now you could see that this is the normal ocular globe, and you could see that the left ocular globe is showing you a T1 hyper intense lesion. So the moment you see, I'm just removing it and then now you can appreciate it much easily. The T1 hyper intense lesion within the ocular globe in an adult patient, the first and the only diagnosis that should come to your mind is malignant melanoma. Now this is so characteristic that if an ophthalmologist even is not suspecting, though normally this does not happen, they already know because of a typical the ophthalmological appearances, but on MR it is very, very characteristic for a malignant melanoma.
So, okay, thank you for the valuable information. So, I think we can take away, have a takeaway message for malignant melanoma, intraocular adult 40 to 70 years of age, along with the male, along with the photopsia because of the impingement of the rods and cones, because of the impingement of the vessels, it is also painful, and sometimes you also get the orange color patches in the RPE, that is due to the accumulation of lipofuscin. We have sent the patient, they are able to see a dome shaped mass as he told us, and what you know, tumors are very much known for causing the ERD, exudative RD, and you should also know the shifting fluid sign. This was again asked in NEET 2020. Shifting fluid sign is very, very pathognomic feature of the ERD, so maybe they will give you not with the name of ERD, they will say exudative retinal detachment causing the shifting fluid sign, and along with your CT and MR images, then you are sure. And even if they say that the patient is coming with pain and photopsia and they have not given the ultrasound picture, then according to you, sir, this MR picture is characteristic. It is characteristic. It is more than sufficient to make a diagnosis. Okay, so now we are clear with the diagnosis of malignant melanoma. So let's come up to the intraocular tumor in the children. So this is a very very interesting tumor, retinoblastoma. जैसे कि मैं बोलती हूँ कि blue baby is your ophthalmos. Similarly, this is your white baby, leukocoria, and this baby is a very very versatile kind of baby because they can present with the unilateral tumors also. They can present with bilateral tumors, and we will be discussing about the trilateral retinoblastoma also. So whitish pupillary reflex. What I always tell you, whitish pupillary reflex, 1.5-year-old child with the calcification. So can you see in the picture? Now this baby can present with the unilateral leukocoria also, bilateral leukocoria also, and then we have series of the signs that they can present with. Now according to one study, they said that the first most common presentation is leukocoria, but after that, like I always tell you, it is leukocoria with squint. But there was one study, in one of these studies they say that even glaucoma was more common in comparison to the squint, so that is controversial. More common is either the squint or it is glaucoma. According to one study only, it is due to glaucoma, but otherwise it is squint only. So this baby can be presenting your secondary glaucoma with the ophthalmos. Now how to compare the ophthalmos and this baby? So you will not get typical 1.5-year age, plus you will not get leukocoria and ophthalmos. Always remember, blue baby boy was your ophthalmos. There you were getting the BPL card, you were getting the frosted glass appearance, you were getting the harp stria. So this is very very different. Now this baby is also coming with a pseudo hypopion. So it is mimicking a acute inflammatory condition, and sometimes the picture is exactly of the orbital inflammation. So at that time there is a confusion that whether it is cellulitis or not. But the moment you open up the eyes and you get a whitish pupillary reflex, then you are sure, no, we are talking about the tumor. Now you should also know about the DD of leukocoria. If I am talking about leukocoria in a child, it can be a congenital cataract also, it can be a Coats disease also, it can be a PHPV also, and it can be endophthalmitis. Some of the babies also come up with the ROP. Now that is a separate entity, and we will be recording a separate video for this retinopathy of prematurity. But of course that will not be coming along with the calcification, along with the inflammatory lesion. And as you know that this tumor is actually arising from the blast cells of the retina. That is why the evidence of orbital invasion is again very very common. So I would like you sir to tell us that how we can actually differentiate this tumor.
So if you look at the imaging appearance of retinoblastoma, I think Dr. Niha, you have already summed up almost every aspect. We have got two aims of the imaging in a case of retinoblastoma. The first thing of the aim of imaging is to confirm that the eye that you are mentioning has a retinoblastoma. The second important thing is retinoblastomas are known to be bilateral. So in case of these bilateral retinoblastoma, you need to see the other eye, because there are chances that there is a very very subtle or a very very small retinoblastoma that is present in the other eye, and sometimes you need to see the extent of the retinoblastoma, that whether it is just in the ocular globe and going into the intraorbital location, or sometimes it is extending along the optic nerve into the brain parenchyma. So we look at the calcification. Now we know that the CT is the most useful imaging investigation to pick up a calcification. So this is the CT scan, and as you could see the calcified mass into the left ocular globe, and not just the left ocular globe, you can also see the focus of calcification in the right ocular globe over here. Okay, so that means that this patient has a bilateral retinoblastoma. That's a very very important point that an ophthalmologist is asking me. Okay, now but over a period of time, there is a very interesting thing that I want all of you to understand, is that the gone were the days when we were doing actually CT scan for the diagnosis of retinoblastoma. The reason behind that is that because CT involves a lot of radiation, and these are pediatric age group, we do not want to give too much radiation to these patients, and over a period of time the ophthalmologist has stopped sending the patient to us for a CT scan. Now what we do nowadays is a simple B scan helps us in identifying the mass lesion, and these bright foci within the mass suggests the foci of calcification. So usually an ultrasound is sufficient to make a diagnosis in a clinically suspected case of retinoblastoma. However, the ultrasound has a limitation over here, and that limitation is the ultrasound will be able to tell you only the intraocular mass, that whatever the mass, the endophytic mass that is present in the globe will be able to be appreciated best. ultrasound. Whereas we know that these retinoblastomas are known to extend along the optic nerve. So the extent along the optic nerve and into the brain parenchyma will be best appreciated on MRI. So nowadays the standard investigation that is done in a patient with retinoblastoma, it has been asked in the NEET exam few years back also, is not a CT scan but an ultrasound plus an MRI examination. Now the ultrasound will confirm the intraocular mass and then MRI will give me the complete extent of that particular lesion. So if we look at the ultrasound appearance, again you will see a mass along the posterior aspect of the globe with or without retinal detachment, which might be there or might not be there, and sometime you will see some foci into the vitreous chamber also. So that will confirm the case of a retinoblastoma. Now if you look at the MRI, now you could see that there is a mass. This is a T2 weighted MRI. As you could see, the vitreous is appearing so white. You could see a mass going into the intraocular globe, and you could see the bulky optic nerve going up to the orbital apex as well as right up to the optic chiasma. So that's a complete extent of the retinoblastoma, which is very well appreciated on this particular scan. Okay. Now here I would like you to see one more image. Now what I could see is, if I'm going to show you this image, you could see the mass into the ocular globe. Along with that, you can see a mass in the suprasellar cistern and as well as the mass in the region of a pineal gland. So that's a classical appearance of what is called as a trilateral retinoblastoma. Trilateral retinoblastoma, when along with the retinoblastoma, you could see that the mass in the other ocular globe also. So along with the retinoblastoma, you are seeing a mass in the region of pineal gland which is extending right up to the suprasellar cistern. So that's a case of a trilateral retinoblastoma.
So I think this is a very interesting thing, because in the class also we always find it very interesting that there is a term called as trilateral retinoblastoma, and today we are able to see it. I would like to take an opportunity, Dr. Rajat, please help our students to find out when it is T1 weighted image and when it is T2 weighted image of the orbit, because in the classes we don't get that amount of time, and today we have got Dr. Rajat here so that we can actually find out, because for you it's very easy and they are actually confused whether it is T1 weighted or T2.
No, so for the orbit, this is the most easy thing. Look at the ocular globe. You can easily appreciate the ocular globe, and you know the simpler way to remember is World War II. Water is white on T2. Okay, so the vitreous is fluid.
Yes.
Vitreous is water.
Vitreous.
So World War II. If the vitreous is white, it is T2. If the vitreous is black, it is T1. Period. That's all. That's the easiest way that you can identify the image of a T1 and T2,
I think the
specifically
most
in the eye.
important part of today was remember the World War II. I think that I have also learned this today, and you people also learned this today, because it is after knowing this, that this is T1 or T2, first of all the students get confused whether it is T1 weighted image or it is T2 weighted image. So I thought that I will definitely ask this Dr. Rajat to clear this thing. So okay, thank you sir so much. Now I would like to go to the other one, that is in the intraorbital lesions, and I think they are actually creating more kind of a trouble, because these are the lesions which are more responsible for causing the proptosis, and you already know that secondaries are the most common cause of the bilateral proptosis in children, while if it comes to unilateral proptosis, it is the orbital cellulitis. So if I talk about the rhabdomyosarcoma, now this is again a very mimicking kind of tumor, though it is malignant, and always remember, like the malignant melanoma, this is also more common in males. That was 70 years, this is 7 years. Now always remember 7 and 70, it is more common. So if you see this rhabdomyosarcoma, this is giving you a very acute inflammatory kind of picture. So just by the sight, you don't have a slightest clue that actually this can be a tumor, and we usually get admitted this patient for the orbital cellulitis thinking that it might go into cavernous sinus thrombosis, and then we send to the radiology department and we get something else. So sir, will you give us some insight that how to diagnose this rhabdomyosarcoma, because it's a very malignant tumor arising from the muscle cell. So I would like to request sir to tell us something about this.
Okay, so if you look at a rhabdomyosarcoma is a very, very malignant tumor. If you look at in the orbital region and the pelvis region, these are the two areas where we commonly see. In the pelvic region, it's commonly originate in the boys from the prostatic region, whereas in adult, if you're gonna look at it, the commonest source of origin is the muscles. As the name says, myo means muscle. The sarcoma of the muscle is basically if you're gonna look at the name. So it is originating, one of the important area which is gonna involve it is the muscle. Okay, so as you could see in this particular image, now we already know the conal, extraconal and the intraconal. So there will be an involvement of a muscle. Okay, there will be an involvement of a muscle, though the history is very characteristic on that particular case, and usually it is involving the pediatric age group. Now, but here I want you to specifically mention that this kind of uniform or the marked enlargement of a muscle, that you're gonna think of that when a clinical suspicion of a malignancy is being there, then we're gonna label the patient that this is a suffering and with an infiltrating kind of lesion, which is infiltrating, sometime involving the lacrimal gland, sometime extending into the conal compartment as well as the intraconal compartment, and going extraconally also, an infiltrating mass involving the muscle. Think of a rhabdomyosarcoma. Now, very, very important disease that I want to mention here is, which is not relevant at this point of time, which will be helpful for you, is that there is a uniform enlargement of the muscle can also be seen in patients now who have a disease like a thyroid enlargement or a thyroid ophthalmopathy. Okay, now very, very important differentiating feature that let me just see whether we have an image for that or not. Yeah, now see this particular image. Now what you could see is, again you could see the uniform enlargement of the muscle. Now, but what is an interesting aspect that you see here is that the tendon is not enlarged. So that's classically what is called as a tendon sparing muscle enlargement. Tendon sparing muscle enlargement, and if you just try to draw it, you're gonna draw it like this. Draw it like this. So this has been described as a Coke bottle appearance. A Coke bottle appearance with the sparing of the tendon and only the muscle belly that is enlarged. It is very, very characteristic for thyroid ophthalmopathy. Whereas if you look at the infiltrating mass, now if you look at the MR image of this particular patient, you see an infiltrating mass that is infiltrating, originating from the muscle, going into the intraconal, going into the extraconal compartment. In a case of a child, think of a rhabdomyosarcoma. And as Dr. Niha, you were pointing it out, now see, it is so simple. You can see, look at the ocular globe. It is so black from inside. So this will be T1 weighted MR. Yeah. So this is a T1 weighted MR, and you could see an enhancing mass because this is a post contrast MRI. This is another interesting aspect. The post contrast MRI is always a T1 weighted MR. It can never be a T2 weighted MR. So all this white that you could see is not the fluid but the enhancement in the tumor. So that's rhabdomyosarcoma from a radiological perspective. But I also feel that as far as images are concerned, even if they want to give you a slightly difficult question, a malignant melanoma and retinoblastoma are the two image based questions that could be there in your exam. The rest of the CT and MR images are very, very unlikely to be there in the exam.
Yes, they are towards the PG, I think,
exactly.
Beyond their scope. But one thing that he has mentioned is very important, because proptosis in adults means thyroid ophthalmopathy, and in thyroid ophthalmopathy, the sparing of the tendons is a very important point, and I think that image you can definitely get,
because that can be there.
And they always ask you which part of the muscle is involved. It is the whole belly part that is actually involved, along with the sparing of the tendons. So both origin as well as insertion will be spared, and that will give you a very beautiful sign, the Coca-Cola bottle, as the sir said, that you are going to get. Now also, sir, I want to know that how actually orbital metastasis will look different from these pictures, because though it's not very common, but 6% of the patients also suffer from this metastasis, and actually metastasis is also causing the proptosis in cases of children. So let's see the pictures.
Yeah. See, as far as orbital metastasis is concerned, I will say that usually what you'll see is the bony destruction. As you could see in this particular case, now this is a case of a known prostate cancer with a metastasis. As you could see that there is a irregularity and with some subtle the periosteal reaction. Now one thing that I want to mention specifically for the exam point of view is that these are non-specific images. These are the non-specific features, and it is not practically possible even for us as a radiologist to label them definitely as a metastatic deposit. But when you see irregular bony destruction in a patient with known malignancy in some area and you see these masses, then you think about, along with some amount of soft tissue that is coming, then that labels the diagnosis of metastasis.
So
obviously,
you mean to say that they are actually the diagnosis of very, very high suspicion?
yes.
Only then you are
Yeah,
able to
like you know, there is a malignancy, you have done a PET scan and you are seeing the FDG uptake in that particular area, then they're gonna label it as a metastasis.
And plus we also know that the orbital metastasis is very common from certain tumors.
Yeah,
So if you have history of
exactly,
those
yeah,
tumors,
neuroblastoma. Like neuroblastoma is one. Like in a pediatric age group, if a patient has a known neuroblastoma and you see a proptosis, then the first thing that comes to your mind is that this child is having a orbital metastasis. Definitely.
So I think this is actually the secondary diagnosis. So
Yeah.
if you are having neuroblastoma, please check for orbital metastasis.
Exactly.
It is
Yes.
something like this.
Yes.
So I think we have summed up all the important tumors, and let's begin with the takeaway messages one by one.
Yeah.
To begin with, the first was the malignant melanoma.
I
of
feel
the
that
forehead.
before going on to take home message, I again want all the students should remember this particular table. Now the way that the tumors have been summed up in this particular flowchart, I'll say that this is one of the most useful take home message from this particular session, that if it's an intraocular mass in adult, the first thing that should come to your mind is malignant melanoma. If an intraocular mass in children, the first thing that should come to your mind is retinoblastoma.
Exactly.
If it's an intraorbital mass in adults, we know it's usually a benign tumor, which will be cavernous hemangioma. And if it's an intraorbital mass in children, which is usually a malignant, think of a rhabdomyosarcoma. I will say that more than 80% of the things can be addressed on the basis of this particular part. So that's the first take-home message that everybody should take. The second message that I think that they can take is melanomas are hyper intense on a T1 weighted MR. Okay, from the radiological perspective, you can take the ophthalmological takeaway messages later. Then from the malignant melanoma, T1 hyper intense mass. That's a very, very important point. The second point is involvement of the muscle. Infiltrating mass is a characteristic appearance of rhabdomyosarcoma. Third, calcification in a mass is diagnostic for retinoblastoma. Though calcifications are best seen on CT, nowadays the diagnosis is predominantly made on ultrasound and the extent of the lesion will be assessed on MR.
So one thing, Dr. Rajat, if they ask them that after ultrasound, what should be the investigation of choice? So should they mark MRI?
Yes.
Not CT scan?
No, not CT scan.
Not
CT scan no longer we perform.
Okay.
We do not perform a CT scan. In fact, the problem is when they ask you that straight away shall we go for an MRI? Then I'll say no, not really.
Not really.
The reason behind that is that nowadays this facility of the B scan is available in the ophthalmology department.
Yes, many of us are doing like
it is available in an ophthalmology department. So you really do not need us. You see a white reflex, you do a retinoscopic finding, you are suspecting that there might be a mass, you do your own B scan.
But then too we require like MRI because we want to know the other eye involvement.
So once you have done the ultrasound and you know there is already a mass, then you want to see what is the extent.
Yes.
What is the extent? Is it the optic nerve? Because the optic nerve is one area that you will not be able to see completely
by the ultrasound.
On your ultrasound.
And our treatment modality actually depends upon the extent. So we actually require the radiology department very much.
Yeah.
So, okay. So please continue about the other ones you were telling about.
So from my side, I think these are the important take-home messages that one should take. One extra which is not related to the tumor is a Coke bottle appearance or the tenderness sparing is a special feature for a thyroid.
And that is a very important thing, and I think I have seen this question to be asked in many of the papers. It is very frequently asked question.
So if when talking about thyroid ophthalmopathy, we also know that the most common muscle involved in thyroid ophthalmopathy is inferior rectus. Okay, so that is another one that has been asked a lot of time in the exam.
Yes. So for that, in the continuation, I always tell you that always remember the IMS Lucknow. So inferior rectus is the first, then is the medial rectus, then it is the lateral rectus, and then it is the oblique.
So we used to remember it as I am slow.
Okay.
So we are the way that you make the mnemonic is on the basis of your life.
Of your life. It is
so I am slow. So that is why we have made it like I am slow, and that's the same as IMS Lucknow.
So yes, but the thing is same, inferior rectus, then it is medial rectus, superior rectus, and then it is lateral rectus.
And then obliques.
Now please don't ask which oblique, because still it is not clear that which oblique is involved first, but yes, certainly obliques are involved after the recti, your coke bottle appearance, the sparing of tendons, and in adults, proptosis means thyroid ophthalmopathy. These are the very, very important takeaway messages. And one more thing I wanted to show you, that there are two kind of retinoblastoma. One is the endophytic type and one is the exophytic type. So the endophytic type is usually causing that collar stud appearance. So this kind of appearance you are going to get in the fundus. Though these are not that kind of images which can come just in spot diagnosis, they will always be supportive, but if you have already seen them, obviously they will help you a lot. And another is your exophytic. Now when it is exophytic, obviously then it can lead to proptosis. So why I want to show that retinoblastoma cannot present as proptosis, while rhabdomyosarcoma will present as proptosis. So this will help you in differentiating whether it is your intraocular or intraorbital tumor. And as the sir has already said in the last, remember this flowchart, and this will help you a lot solving lot of questions related to the tumors, related to the mass, along with the proptosis. So I would like to thank Dr. Rajat for giving us insight in the radiographical representation of the tumors. I hope you enjoyed the video and have learned a lot of new things like me, the World War II on the MRI. Please comment in the comment section what are the other integrated things that you would like to have along with the ophthalmology, and what other thing that you want the sir to tell with respect to the ophthalmology, because I'm really looking forward to catch hold of him one more time so that we can have more of the radiological aspects of the ophthalmology. Thank you and bye-bye.
Thank you very much, friends, and keep learning, keep reading, and keep bugging us with your innumerable doubts that you have.
Yes.
We are always available for all of you. Do not think twice. If you have any problem, we are there for all of you.
We are really looking forward.
Yes.
And we are more than happy to solve your doubts.
Yes.
Thank you.